Yeah, I don't know why that is. I'll give them a few more minutes because they always come in after the deadline.
Okay. I have to remember what I said on the slide.
Good afternoon. May I have your attention? Thank you. Our speaker today is Erin Butler, who is a Neukom Fellow here at the Thayer School of Engineering at Dartmouth. Erin's research uses three-dimensional motion analysis and advanced neuroimaging techniques to better understand and improve the treatment of human motion disorders. Erin holds a Bachelor of Science in Engineering in Bioengineering from the University of Pennsylvania and a MS in Mechanical Engineering and a PhD in Bioengineering both from Stanford University. Please welcome our speaker.
Okay. My name is Erin Butler, and I'm going to be presenting work that I did as part of my PhD thesis at Stanford, Quantitative Analysis of Upper Limb Motion Among Children with Cerebral Palsy. And I am now currently a postdoc here at Thayer, so I look forward to interacting more with some of you. So by way of introduction to the research question, let me just point out the obvious. The ability to reach, grasp, transport, and release objects is central to activities of daily living, such as eating, drinking, personal hygiene. However, children with cerebral palsy and upper limb disorders often have difficulty performing these seemingly simple tasks. So our goal with this research was to develop a comprehensive quantitative analysis of upper limb function for children with cerebral palsy, and in order to improve the evaluation and treatment of upper limb movement disorders, to help these children live full and enriching lives. So you've probably heard of cerebral palsy, but you may be thinking, what exactly is it? Let me explain or refresh your memory. It's a group of permanent disorders of the development of movement and posture that limit physical activity. The motor disorders are often accompanied by disturbances in perception, sensation, cognition, communication, and behavior. They often have epilepsy and secondary movement problems, musculoskeletal problems, such as muscle contractures or bony deformities. Cerebral palsy is attributed to non-progressive disturbances that occur to the developing fetal or infant brain. Neonatal stroke in full-term infants is associated with a lack of oxygen to the brain. It doesn't come out very well. A blood clot can occur. You get occluded vessels, a lack of oxygen to a specific area of the brain. Additionally, there can be a deprivation of oxygen around the time of birth. You have oxygen-poor blood circulating through the brain, and this leads to a diffuse white matter injury. Preterm infants typically suffer from two other types of brain injuries that probably result from the delicate nature of the developing human brain. Can either be related to an intraventricular hemorrhage, where you have blood pooling in the central cavities of the brain or the lateral ventricles, and that can enter into the brain space as well and lead to death of white matter. Periventricular leukomalacia leads to focal cysts that damage the white matter tracts, which transmit signals from the brain the rest of the body. The incidence of cerebral palsy is 2 to 3 out of 1,000 full-term infants. But that number jumps dramatically when we look at low birth weight, very low birth weight preterm infants. It's 15% of these children born before 32 weeks gestation and weighing less than 1,500 grams, which is about 3.5 pounds. Cerebral palsy varies in terms of severity and topographical distribution, which means which limbs are affected, as well as the specific type of movement disorder that's associated with it. In spastic cerebral palsy, it's characterized by spasticity, which is a velocity-dependent increased sensitivity to stretch. We also see a loss of independent or selective motor control. If you ask them to tap one finger, the whole hand goes, or maybe even the whole arm moves. There's often significant muscle weakness and shortened muscle tendon unit, meaning that the growth of the muscle and the tendon doesn't keep up to the growth of the bone. In dyskinetic cerebral palsy, it's characterized by either dystonia or athetosis or both. Dystonia is defined as a sustained or intermittent muscle contractions that cause twisting, repetitive movements, and or abnormal postures. Athetosis is defined as slow, continuous, involuntary writhing movements that prevent maintenance of a stable posture. This girl has a combination of both dystonia and athetosis. Ataxic cerebral palsy is characterized by ataxia, which is an inability to generate a normal expected voluntary movement trajectory that cannot be attributed to weakness or involuntary muscle activity of the affected joints. It's often associated with damage to the cerebellum, so it affects the vestibular system. So you see, I ask her to just simply reach for the cup, and what's happening? And sorry.
What kind of videos are
They're WMVs.
You might want to click on the image itself.
Okay, we'll just go to the next slide. But
Let me get Roger.
sorry. Well, sorry about this. Seems like the connection's going in and out. Okay, I'll try not to move. Oh, darn. Okay. So, cerebral palsy, I think I've demonstrated that it presents a clear problem in a large number of preterm children and varies in severity and type of associated movement disorder. The current methods that are used to characterize upper limb deficits and treatment outcomes, however, they're primarily subjective and observational, meaning they require a clinician to observe the child, perform a number of tasks. If I don't move, it seems to be okay. And this obviously leaves room for improvement by quantifying the movements with the use of three-dimensional motion analysis. 3D motion analysis is typically routinely used for gait analysis for individuals with gait disorders. In addition, the differentiation of different movement disorders is critical for determining the appropriate type of treatment for children with cerebral palsy. For example, a treatment for spasticity may not be as beneficial as for a dyskinesia. So the objectives of this study were to characterize kinematic and temporal spatial parameters of a reach and grasp task using three-dimensional motion analysis in a group of typically developing children, as well as a group of children with cerebral palsy. Second and third objectives were to develop and validate a quantitative index of upper limb function during a reach and grasp task based on joint kinematics, and to develop a diagnostic tool to differentiate between different types of upper limb movement disorders. So the first objective was a combination of two papers, kinematics and temporal spatial parameters of the upper limb during a reach and grasp cycle. We developed the reach and grasp cycle based on a review of observational clinical tests. It's a sequence of tasks that incorporates all major joints of the upper limb and simulates a functional task that is both feasible for the child with cerebral palsy and yet challenging enough to reveal motor deficits. So the child is seated at a table with their arms flexed. They're asked to reach forward, grab a cup, bring it up to their mouth to simulate drinking, return the cup to the table, and bring the arm back to resting. So we had 30 typically developing participants from 5 to 18 years of age. They had no history of orthopedic or neurological abnormalities. We had 25 children with cerebral palsy. It was a convenience sample, so it just happened to have more females than males. Same age range, similar mean age in children, and all children had an upper limb impairment involvement. And the manual ability classification scale, which measures a function, ranged from 1 to 4 in this group. So 1 would be mild impairment, so maybe some slowness or some clumsiness in doing a fine motor task, all the way up to, it ranges up to 5, which is basically an inability to use the hand in any functional manner. So we had a max level 4 is the greatest measure. And the children had a primary diagnosis of either spastic, dyskinetic, or ataxic cerebral palsy. So the participants were all had light reflective markers were placed on the upper body, on the skin at specific bony landmarks. We placed a cup at 75% of each individual's maximum reach. We then asked the typically developing participants to perform the task with their dominant hand. We asked the children with cerebral palsy to perform it with their more involved hand. And we used an optoelectric motion analysis system to capture the three-dimensional position data from the participants during the reach and grasp cycle. Here's another video. Let's see. So the colored balls here represent the markers that are placed on the skin. The crosses indicate the joint centers that are calculated from the external markers. There's also one on the cup. So from these little dots, we calculate the joint kinematics using an upper limb model. Joint kinematics were calculated according to recommendations put forward by the International Society of Biomechanics. There were 9 segments. The joint centers were calculated from external markers, and we used a joint coordinate system to calculate the joint kinematics. As with any model, there were a number of assumptions. Specifically, we looked at glenohumeral motion only. We disregarded acromioclavicular and scapulothoracic motions. So there's actually 3 shoulder joints at the shoulder. We looked at the main motion between the humerus and the trunk. Shoulder abduction and flexion were described as shoulder elevation to minimize any ambiguity with the clinical definition of shoulder abduction and flexion, because true clinical shoulder flexion is at 45 degrees away from midline. So this is flexion here. But this assumption is based on a recommendation from the International Society of Biomechanics. Elbow motion was primarily uniplanar, meaning we were just looking at flexion and extension. Forearm pronation and supination was calculated along the long axis of the lower limb, the lower arm. So it was the rotation of the flexion extension axis of the wrist with respect to the flexion extension axis of the elbow. And finally, the last assumption was the use of external markers to calculate the joint centers. This is a standard procedure in 3D kinematic studies, but there are soft tissue artifacts and there's a lack of precise pediatric population offsets, which contributes to systematic error. So I have to mention that. So we use the 3D position data recorded from the cameras to calculate 8 primary motions of the trunk and upper limb. So without tipping over, I'll try to show you. Trunk flexion and extension, trunk rotation. We looked at external and internal shoulder rotation, elevation, as I mentioned before. I got those. Elbow flexion and extension, wrist flexion, extension, forearm pronation and supination, and then ulnar and radial wrist deviation. The temporal spatial parameters were calculated from the 3D positions of the wrist joint center. It's represented by the little yellow dot. We looked at the total time to complete the reach and grasp cycle, the duration of the individual phases, the peak velocity of the wrist marker during the reach, transport 1, transport 2, and return phase, percent phase at which peak velocity occurred, the index of curvature, which is the directness of a movement measure, and the number of total movement units, which shows how smooth the movement is. So this is the first participant with cerebral palsy, or one participant. You'll see, I hope, that she has increased forward and lateral trunk lean, increased shoulder elevation to compensate for her reduced elbow flexion, and increased wrist flexion. Participant 2, compared to the participant 1, has more upright posture, but she has increased wrist radial deviation and increased forearm pronation compared to the first participant. And she also has reduced elbow extension, you may have noticed. So here's one of the 8 kinematic graphs that were calculated. Come on. Okay, so this is elbow flexion and extension. I'm sorry. I don't know if it's my videos or what. So this is as a percent of the reach and grasp cycle. So the arm is flexed at initial contact. At the beginning, start. It extends during reach. Flexes again as you bring the arm up to the mouth, extends to return the cup to the table, and flexes again slightly to bring the arm back to the resting position. Okay, this is all 8 of the graphs. We've got the typically developing mean in yellow, plus or minus 1 standard deviation, and then we have 2 different patients with cerebral palsy, the 2 that were shown in the video. So the first participant, you can see that she does indeed have increased trunk flexion. Both girls had reduced elbow extension, and the first girl has this increased wrist flexion. The point is that you can see clinically significant differences between the patients with cerebral palsy and the typically developing population, as well as differences between patients. Now, the total movement time was statistically significantly different between the typically developing population and the children with CP. Children with CP took almost twice as long to perform the task. The durations of the individual phases of the reach and grasp cycle are displayed here. The typically developing population is in black. And we can see that the transport phases, which is T1 and T2, for the typically developing population are statistically significantly longer than the non-transport phases. We did not see that same trend in the children with cerebral palsy, the ones in gray here. The kids with CP had much longer grasp and release times, which contributed to the overall increased movement time. If we look at peak velocity, there's no significant differences between the typically developing children and the children with cerebral palsy. But if we look closer at the typically developing children, the black bars, we see the peak velocity, again, was greater during the transport phases, so when the cup is in their hand, compared to the non-transport phases. So the hand travels a longer distance during the transport phase, so from the table up to the mouth, as compared to across the table. So you get greater peak velocities in the typically developing population, and that's consistent with a concept of scaling movement velocity to movement amplitude. In general, the children with cerebral palsy did not demonstrate this pattern, and that suggests a more limited ability to modulate their hand velocity. Index of curvature was defined as the distance that the wrist traveled divided by the linear distance between the start and stop positions. This value is calculated in 3 dimensions. So if the wrist takes this path, we divide that by the linear distance to get the index of curvature. So it shows the directness or indirectness of the movement. We found significant differences in the index of curvature between the two populations for the reach and return phases. Among the typically developing children, we did see, again, a significant difference between the transport and non-transport phases for index of curvature. So the number of movement units represents the total number of local maxima and the velocity profile of the wrist marker. So here we have a plot of wrist marker velocity for the reach phase only. You can see for the typically developing patient, there's a nice bell-shaped curve, represents 1 movement unit. The individual with cerebral palsy has a much jerkier movement pattern, and we end up getting 5 movement units. So there's an increased number, we found an increased number of movement units for the children with cerebral palsy during each phase, that's statistically significant during reach, transport to, and return, as compared to the control participants. So new measures are only useful if you can prove some validity. So we looked at the validity or clinical usefulness of the temporal spatial parameters evaluated by testing the statistical correlation between these parameters and the standard clinical measure of function, which is the manual ability classification scale. And we found a strong correlation between this manual ability classification scale and the parameters of total movement time, index of curvature, and the total number of movement units. So this suggests that we've come up with some useful, potentially useful measures. So to wrap up this half of the study, we can say that we found consistent normative kinematic and temporal spatial data. We found clinically significant differences between the children with cerebral palsy and the typically developing children. And the reach and grasp cycle offers a standardized protocol to measure upper limb function and provides a quantitative analysis of motor deficits. So based on the results of the previous work, I want to move forward and discuss the development of the what I called the Pediatric Upper Limb Motion Index, or PULMI, and a temporal spatial logistic regression analysis. So the objectives here were to develop an index based on joint kinematics during the reach and grasp cycle that could quantify the severity of upper limb motor deviations. Then we needed to validate this index with standard clinical measures. And third, develop a diagnostic tool to differentiate between the different types of movement disorders, specifically looking at spastic versus dyskinetic cerebral palsy. And I'm focusing on those two groups because those were the two largest populations. I only had 2 children in the ataxic cerebral palsy population. That's obviously not enough to do any statistics. So based on the previously collected data from the 30 typically developing children, we had this mean value here for elbow flexion and extension. We calculated the root mean square difference between this mean line and the patient line. So the difference, RMS difference, root mean square difference is in red. We calculated that for each of the 8 kinematic variables. Now the kinematics, shown here, will then inform our movement profile. So each of these bars here represents an RMS difference between the kinematic graph from the typically developing mean and the patient. So for example, wrist flexion extension here is very large. We get a large difference between the patient and the typically developing. And I should also say that in black is the mean typically developing RMS difference. So this is above and beyond what that difference is. If we take these 8 measures and calculate the mean, we get an average value here, and that is what I'm going to call the raw POMI score. So when we plot that for the typically developing children on the left, we see that we get a normal distribution, more or less. For the children with spastic CP, we're here in red, and in blue, the children with dyskinetic cerebral palsy. And there was a significant difference between these two populations. In order to improve the clinical usefulness and interpretability of the raw POMI score, I transformed it and scaled it such that the max POMI score is 100, and then every 10 points that the child's score falls below that 100, that represents 1 standard deviation away from the typically developing mean. There's a lot of methods involved there if you're interested. Richard Baker and Mike Schwartz have a nice review of that. But the take-home point here is that the typically developing mean is 100 plus or minus 10. So, for example, we have 2 movement profiles here. This is a child with spastic cerebral palsy. So we can see each of her 8 kinematic graphs here, the average, so the raw POMI score, and which computes to a POMI score of 75. So that means she's 2.5 standard deviations below the typically developing mean. This patient here with dyskinetic cerebral palsy, based on her RMS profile and the average, it comes up with a POMI score of 31, or 7 standard deviations below typically developing mean. So this may be useful if we're looking at before and after an intervention. We can say, before they were 7 standard deviations below the mean, now they're only 4 standard deviations below the mean. It's not great, but it's much better. And it gives us a way to quantify that difference. And again, just because we use computers and complicated equations doesn't mean that we've come up with anything that's clinically useful. So we have to validate our new measure against existing clinical standards. So if we plot our POMI score here with the max or manual ability classification scale, which is the clinical standard of function, we do get a good correlation of 0.8, which shows that this method or measure is valid for this population. In addition to validating the measure, we also have to make sure that it's repeatable and consistent. And this is done through analysis of inter-session reliability. In this case, we found high reliability for the POMI score, as well as 4 key temporal spatial parameters that I suspected might be useful in distinguishing between movement disorder subtypes based on the previous work that I did. If we look more closely at each of the 4 key variables, we can see in general that the children with CP, so this is one individual with CP, so we have all the kids here, In general, the kids with CP had a longer movement time. We already showed that in the previous work. Now we're parsing it out by individual movement disorder type. There's no statistical difference between the two, but there could possibly be a trend toward the children with dyskinetic cerebral palsy taking longer than the children with spastic cerebral palsy. Index of curvature data here for the spastic and dyskinetic children. Again, no statistically significant differences, but perhaps a trend. For the number of movement units, we did actually find significant difference between the two groups. So that with the dyskinetic CP group having more movement units per reach cycle than the children with cerebral palsy. So less smooth movements. They had jerkier movements during the reach and grasp cycle. So this difference is obviously important, but it may not tell the entire story. If we look at the ratio peak velocity for the transport phase, which was, remember, bringing the cup up from the table to the mouth, dividing by reach, we found in the typically developing population that there were greater peak velocities during the transport phase than the non-transport phase. But children with cerebral palsy did not demonstrate the same behavior. So this is the typically developing line. We would expect, if they had a similar scaling pattern, that they would be along here, but they're mostly below. So remember, our goal here was to predict a spastic versus dyskinetic movement disorder type. The individual temporal spatial parameters they picked out may not be robust enough to be able to differentiate between the two types, but put together, we may be able to form some sort of predictive ability. But how do we do that? The answer, according to my statistician, was the multivariable logistic regression. So this is a type of statistical analysis which estimates the relationship among variables. It's used to predict the outcome of a categorical dependent variable, which was spastic versus dyskinetic, CP, and based on one or more predictor variables. So we had movement time, an index of curvature during reach, total number of movement units, and the ratio of transport 1 to reach peak velocities. And using a logistic function, the probabilities describing the possible outcomes for a single trial are modeled as a function of the explanatory or predictor variables. Basically, you want a model with predicted values that match your observed values as closely as possible. So when I plug in the 4 different variables, I get this type of equation here. So this gives me a weighting for each individual variable. And it was able to correctly classify 19 of 22 movement disorders, so spastic versus dyskinetic. So 12 of 13 spastic CP cases and 7 of 9 dyskinetic CP cases. The kappa coefficient, which provides an assessment of the percent that's correctly classified, corrected for the amount that would be classified by chance alone, is 0.7. And so that's pretty decent, apparently. So the overall impact of this work, we found a repeatable protocol using 3-dimensional motion analysis. We found consistent kinematic and temporal spatial parameters during the reach and grasp cycle. Found clinically significant differences between children with cerebral palsy and controls. Developed a quantitative measure of upper limb function. And then using a logistic regression equation, we came up with a way to improve the diagnosis of movement disorders in cerebral palsy. So potential applications for long-term, again, differentiating between the different types of movement abnormalities. There are a number of treatments that are available which are indicated for specific movement disorders. And by being able to correctly distinguish between the two types, we can ensure that the appropriate treatment is given to the patient. This will help guide treatment decisions for upper limb abnormalities in children with cerebral palsy. The main treatment options would typically be Botox injections, constraint-induced movement therapy, which is where you would constrain the less impaired arm and force the child to use their more involved arm to strengthen the white matter tracts. Orthopedic surgery or functional electrical stimulation, which is electrodes placed over the muscles that are activated at a specific time to elicit movement. Evaluation of pre and post intervention. And finally, an examination of structure-function relations between brain abnormalities and motor deficits. So these are a few of the people for whom I need to thank, and I'm around if anybody wants to talk to me more. Stop by or give me an email. And I talked fast, so now I'm done, and you can leave early. But I'm happy to take questions.
Are there any questions? No? I had an interest in the equipment that you used to do that. You mentioned at the seminar earlier that it was quite costly. It seems to me that this could be duplicated at much less expense. Have you? Is this project still ongoing, or is this ended at this moment?
It's been put on hold. I would like to get back to it at some point. There are definitely ways to streamline it. It may not need the entire optoelectric motion analysis system to do all the kinematics. The temporal spatial parameters seem to provide a lot of information, and that was really just one marker on the wrist, which could be obtained differently.
About that because I have some ideas on how you could do that relatively inexpensively compared to the price you mentioned earlier.
Yes, which is about $200,000 for the optoelectric motion analysis system.
Another thought came to me as you were explaining what cerebral palsy is. I'm surprised that the plasticity of the brain does not compensate for the damage that occurs, perinatally. Is there an explanation for that?
It depends on when the brain injury occurs. If it's before birth, there is quite a bit, because the pruning for the ipsilateral side doesn't happen until after birth. And so if the brain injury occurs before birth, a lot of that pruning doesn't occur, and so you can get some compensation. If the brain injury occurs after birth, like with a stroke, that pruning has already occurred, and so you have those types of abnormalities. But it's not only damage to the white matter tracts, it's like regions of the brain where there's cysts or necrosis. And so there's only so much that can be done. And a lot of times we're getting better with the imaging techniques so we can diagnose cerebral palsy much earlier, but a lot of times it's not diagnosed until they're 2 and they're still not walking, or they start walking and they're dragging their leg. So by that time, the brain has already matured to the point where there's not much that you can do. So
you mentioned that the children, I think they were aged 4 to 18 years old?
5 to 18.
5 to 18 years old. So I imagine their body sizes might be very different.
Mm-hmm.
So have you considered that into your kinematics data?
So I had them reach out, and I measured 75% of their reach. So they were all performing the same maximum reach, or 75% of their individual maximum reach. So it was scaled to their body as much as you can. The dimensions might be a little bit different. That can change with age, but I looked at age differences from 5 to 18 and didn't see anything that was clinically or statistically significant.
And also, I So how would you anticipate that the findings from the study can be used for clinical diagnosis? Do you also need them to wear markers and to analyze whatever motion analysis?
Yeah, so this was designed to be similar to like a gait analysis study where what currently happens is the physician, either the orthopedist or neurologist, refers a patient to the lab, to the motion analysis lab. They have a formal evaluation done in the laboratory with the equipment that's analyzed with an engineer and usually a physical therapist, and then presented back to the physician in a full report.
So is it that CP does not really differ between males and females? Because I saw you have boys and girls, but they're not exactly the same numbers.
Right, there's some studies looking at that, and I think most recently they've found that cerebral palsy affects males slightly more than females. And there have been studies like with twins, and they find that if there's two boy twins and they have CP, they're worse off than if there are two girl twins. Or if you have a girl and a boy twin, the boy twin does better with having a female twin than he would if he had a male twin. But this was a convenience sample, and so I just took what I got. And so I had 16 females and 9 males for the study.
There are no more questions. I invite you to talk to Erin if you have an interest in the subject. Thank you very much, Erin.
Thank you.
If you would think of doing a study like that, I think we could do that with just video and markers. There are some very good techniques for spotting, geometrically designed markers, like a circle with a checker pattern on it, for example, which work very well for tracking in 3D. You can buy equipment that will do that on the order of $3,000, or you can actually implement that with just a video feed without writing a special equipment. I have seen that in action, and it's been around for some time. If you're interested, you can research it a little bit. The company is called Thayer, C-L-A-I-O-N, and they used to be an Israeli company, but now they set up in the U.S. And I think that I haven't looked at their stuff recently, but I think that you could do what you want, just a pair of video cameras, one pair here, and capture the whole motion quick. And that would cost you under $10,000 for sure.
Well, I'm looking into some more like the fMRI.
Sure.
It would all have to be MRI.
But 3D tracking is something that I know a lot about. So if you're interested in doing that, let me know. I think I'm from the instrument perspective, but biology and all that. Over my head.
Hey, my name's Chad. I wondered about how you read your data. That's a quantitative number, one is and does that itself differentiate between two types of cerebral moves? And then, so that looks at severity, and then you've got these two different types, and I was wondering, you've got basically 2 bins for one measurement, you've got 4 bins on another, and I wondered, like, if people use things that present like on a spectrum, and people, if you might say something like, does the max, is that really hard, like, is somebody too definite, or is it really like a 2 shading to a 3, or... That's what I'm saying. Right, so these were really by different personality, different physical therapists that be diagnosed the same bins.
like somewhere here, possibly. Something was loose. It could be. Go ahead. Blinking on and off.
Yeah, I could see it from the instrument.
Yeah. So I don't know. Of course, it doesn't do it now.
Of course
Only
not.
in the
I'm
middle.
gonna act up. What was happening, I was talking to Jared Bennett, and he said he really doesn't know what it's like.
Who knows?
Exactly. We put the board meeting this week, let's hope this works fine for Bill when he gets his speech.
The weird part was that it was like she wasn't touching it and keep blinking on and off. That's just bizarre. I haven't seen that a lot. So, I don't know.
I know at one point before the talk, she was having trouble with the video.
Yeah.
That were in bed, and I'm wondering if we're going to have trouble with it. You want to turn that on?
Yeah, I just figured we're probably being recorded here.
You're off.
We're off. Okay.